pleasure to introduce Dr. Nima Allen, who is our newest member of the UCSF Department of Neurosurgery. He trained at Pittsburgh and then spent a year with Uribe at Barrow. And also I found out yesterday he's a part-time swimsuit model too. So
I didn't know about that.
We can Google his name online.
I think it was part of my contract at UCSF.
But he's going to tell us about the perioperative management of blood loss in complex surgery.
Thank you so much, Leah, and thanks for the invitation. So I'll talk about the perioperative management of blood loss in complex spine surgery. I don't have any disclosures. So this talk is based on two premises that are well supported in the literature, that blood loss is bad and that transfusion is worse. So there are multiple strategies that can be adopted preoperatively and intraoperatively to manage blood loss and minimize it ideally. I thought about the presentation a couple different ways. I think what I thought is probably lists all the different strategies that are supported in the literature, some with good evidence, some with poor evidence, and kind of touch base on all of these, and hopefully we have a discussion at the end. So I'll get started with the preoperative strategies. The obvious one is cessation of medications. The three usual suspects are NSAIDs, antiplatelets, and anticoagulants. There's not a lot of evidence for stopping NSAIDs, but anecdotally, I think a lot of surgeons stop. In Pittsburgh and in Phoenix, I think just about everybody stopped NSAIDs. I think it's also part of it is because of this anti-inflammatory effect that supposedly it does affect fusion. But as far as blood loss is concerned, there's not a lot of evidence for stopping NSAIDs. Aspirin is an NSAID, but it has more of a potent antiplatelet effect. So does Plavix through a different mechanism of action. These medications should be stopped 7 days before surgery. And the reason for that is there's no real antidote for these medications. You could give platelet transfusions for urgent cases, but waiting 7 days allows new platelets to be produced and circulated into the blood. A whole host of anticoagulants. The classic one is warfarin, the vitamin K inhibitor. You can stop it anytime you want. Essentially, you just have to wait for INR to reduce to 1.4 or less. You could accelerate the process with FFP or K-Central or prothrombin complex concentrate. Heparin or Lovenox and Lovenox are antithrombin medications that should be stopped 8 to 24 hours before surgery. You could monitor their effect with PTT and more recently factor 10A, and you could give protamine for reversal. And the more recent direct factor 10 inhibitors have variable half-lives, so you have to stop them 3 to 5 days depending on which medication you're talking about. These are traditionally irreversible, traditionally meaning that when they were first marketed, there were no antidotes for them, but recently there are more and more antidotes available for various different factor 10 inhibitors. Are very expensive. So ideally, you want to wait out the half-life and not use these very expensive medications unless it's really necessary and urgent. These are the different antidotes for different anticoagulants. Next, preoperative strategy. You don't want to start the case in an empty tank. It's been shown that preoperative anemia is associated with poor outcome. It's one of the factors that SRS educates patients for, that if you have a hemoglobin of less than 12, you need to have a workup. Ideally, you can find a reversible cause, but this is not always the case, mainly because some of the complex cases that we do have anemia of chronic disease, and those chronic diseases are very difficult to reverse. There is some evidence, I wouldn't say strong, that you could give iron supplementation or EPO for these cases, but again, not a lot of evidence to support it. Okay, moving on to surgical planning as a preoperative strategy. Dr. Shaffrey touched on this yesterday, that PSO may not be necessary for some of the cases. And this is a recent review from the Turkish group and Dr. Alanay that says that there's a trend globally to use PSO less and less. And the reason is obvious. It's associated with high complication rate, blood loss being one of them. So to avoid PSO, you want to really assess the flexibility of the curve. Supine x-rays in adult cases really helps. Scout view of the CT is a good alternative if supine x-ray is not available. And looking for vacuum phenomenon at the disc that could be leveraged to get your correction. So for flexible curves, you ideally want to use multi-level posterior column osteotomies as opposed to using a PSO. Even in rigid deformity, I saw this study from Korea, I believe, that says multi-level posterior column osteotomies is not inferior to PSO. When you look at the details, the blood loss is only about 200 cc's less. It was statistically significant, but it's not a significant save, but I think it all adds up. And about 100 minutes faster surgery with the similar curves. Again, Dr. Shaffrey touched on this yesterday. Hyperlordotic ALIFs, when you have a vacuum phenomenon, could be very helpful to avoid PSOs. And obviously, it helps with blood loss as well. Another preoperative strategy is the consideration of using MIS or hybrid techniques. And when it comes to these techniques, the patient selection is absolutely key. And there are different ways to select these patients. I think one of the more prominent algorithms available is from the MIS arm of the ISSG, the MISDEF2, that kind of recommends the different curves that could be treated with MIS or hybrid techniques. I'm not going to get into the details, but basically, based on the rigidity of the curve and magnitude of the curve, you could ideally treat them with MIS, with class 1 to 3 being treated with MIS and a hybrid, and class 4 being too rigid and too severe to be treated with MIS. And what are these MIS techniques? Sorry, before I move on to that, circumferential MIS does treat similarly severe adult spinal deformity cases with less blood loss. But again, those similar cases are not the most severe ones. They're more mild or moderate. Well, one of these techniques is PSO, or sorry, MiniOpen PSO. That was popularized by Dr. Wang initially from 2016 in Miami. So the idea is that you basically do a MiniOpen PSO and you perk the rest of the case. So the case from Phoenix with a patient with L4 to S1, fusion iatrogenic flatback that underwent an L5 PSO with percutaneous instrumentation from T12 to S1 and extended to pelvis. Another technique is anterior column release with MIS technique with different gradations, and if you combine it with posterior column osteotomies, you can get more and more correction. Obviously, if you add posterior column osteotomies, you're gonna add to the blood loss problem, but ACR alone could be very powerful. This is an example from Phoenix again, that if you release the anterior longitudinal ligament, you can get a huge amount of correction without the need for any osteotomy. This is something that Dr. Shaffrey touched on yesterday that I think is worth mentioning again, that when you apply these MIS techniques, you applying the same principles and trying to use MIS techniques as a shortcut to bypass these principles is not a good idea. The example that Dr. Shaffrey gave, I thought was perfect, that if you do your ACRs really high up, it's not ideal. It's basically the equivalent of doing PSOs at those levels. And it's been shown that it's not going to work. Okay, the next and last preoperative strategy, moving on to intraop, essentially is dual surgeon. UCSF is one of the institutions that has a tradition of using dual surgeons from two different specialties. It's intuitive that if you have two experienced hands doing the case together, you will do the case faster with less blood loss and with some reports of having less complication. Okay, so intraoperative strategies, starting with some basic stuff. The patient positioning is one of those things that if you don't do it well, you'll pay the price for it, but if it's done well, the case goes smoothly and it goes unnoticed. If you position the patient poorly and intra-abdominal pressure increases, the venous congestion happens and the venous return decreases and blood loss goes up. Also, if you don't position the patient carefully, you will not be able to leverage the residual flexibility of the curve which would require osteotomies to correct. So positioning the patient well could obviate the need for more extensive osteotomies. Again, trivial stuff, exposure. You don't want to slash through the muscle. Meticulous subperiosteal dissection helps sequential exposure of the wound, packing the exposed area, moving on to the next, and leaving pelvis last because it requires an extensive dissection and a lot of blood loss. You probably can't do cases without electrocautery. The more advanced electrocautery is a Aquamantis, or irrigating radiofrequency bipolar sealer electrocautery. That's a mouthful, and it does actually have a cost-effective benefit as well. We did a study in Pittsburgh, saves you about $100 for each unit of blood saved. Patient physiology cannot be ignored. You want a normal body temperature because all your clotting factors is essentially enzymes. If the body is cold, these enzymes are not going to work, so you will deal with more and more blood loss. Managing blood pressure is another important factor that has been proposed to be included in enhanced recovery pathway pioneered by Dr. Hanjo Kim in HSS. There's debate about how low the blood pressure should go. Is it 65? Should it be 70? And when should you do it? Is it the whole case? Is it during the exposure, instrumentation? One well-established consensus is that when you're dealing with manipulation of neural elements, you don't want the blood pressure to be low, especially dealing with the spinal cord. Ultrasonic osteotome. I didn't use ultrasonic osteotome at all in all my residency. In my fellowship, every case that we did was with ultrasonic osteotome, even a simple laminectomy. I don't know how many people in the audience use ultrasonic osteotome regularly. A lot? Awesome. I think it was mainly in the pediatric population. It has a tremendous effect on blood loss. And again, anecdotally, you see it yourself when you do these osteotomies. The tip of the instrument gets really hot and it actually coagulates the venous channels in the cancellous bone. Several studies that shows that it has a huge impact on blood loss. Moving to pharmacological agents, the famous one is TXA. It's an anti-fibrinolytic agent. It blocks the conversion of plasminogen to plasmin. It's a cousin of aminocaproic acid. And when you look at its FDA label, it has 3 contraindications. One is in patients with subarachnoid hemorrhage. This is more pertinent to trauma patients, as these medications were originally developed for that patient population. Supposedly it gives patients cerebral edema. If you have an active intravascular clotting, TXA is contraindicated, and obviously if you have allergy to it. Studies after studies have been shown that TXA saves a lot of blood, and this is in double-blinded randomized controlled trials to retrospective studies. And there is a concern when you give TXA that you could precipitate venous thromboembolism. But that's mainly actually in trauma literature and not necessarily in spine. The only thing I could find was from a study from Dr. Shuba's group when he was in Hopkins, that in tumor cases, if you increase the TXA dose to 2 mg per kg, there may be a tendency to increase odds for venous thromboembolism in terms of in the form of DVT or PE. But an extensive meta-analysis from 216 studies across different disciplines in medicine did not find an association between intravenous TXA and VTE. The dosing, the most common dosing is 10 mg per kg to start, and then 1 mg per kg per hour. There's different stop points, either at the end of the case. I was talking to Dr. Eastlack in Scripps. He does that for 5 hours after the end of surgery. Dr. Mumaneni, I don't know if he's here, he does that even for MIS cases, especially stage cases. So there's different variations in practice. Moving on to the next pharmacological agents, the topical hemostatic agents. Again, you probably can't do cases without these agents these days. I also included topical TXA in this, that it may be a substitute for systemic TXA if there is a concern for risk of VTE. or venous thromboembolism. Studies have shown that they have similar efficacy. I should say that when you look at the FDA label, they don't distinguish the contraindications between topical or intravenous. They don't mention topical or intravenous TXA as distinct entities. So technically, those contraindications do apply to topical TXA as well. This is something that I don't know in orthopedic practice this is common or not, but in skull-based surgery, warm irrigation works like magic. In Pittsburgh, we did a lot of endonasal endoscopic approaches, and warm irrigation hugely helps with blood loss. And I like to use it in open deformity cases. And the rationale behind it is that, again, clotting factors are enzymes. They'll work faster if they are in warm irrigation. Cell salvage is another intraoperative strategy. It does require a minimum blood loss. I think it depends on who you talk to. It's about 300 to 500 cc's before you can actually salvage this blood. It does reduce the requirement for intraoperative transfusion, but not necessarily postoperative. It's been shown in different studies and analyses. And last, I would say, I started the talk by saying the transfusion is worse than the disease, and it's true. And it's been shown in multiple disciplines that it's not a maneuver you want to use as a knee-jerk reflex to correct blood loss, but obviously it's a very powerful tool, but you want it to be targeted. You want to check labs regularly. You may want to use TEG, that's been shown in orthopedic surgery, not specific in spine, that TEG may reduce the requirement for blood transfusions, and you transfuse when necessary. That definition of necessary is really a working definition and depends on the surgeon, and you should work with your anesthesiology colleague to sort that out, hopefully in advance. I should say I actually put anesthesia versus surgeon, but I showed this to my wife, who's an anesthesiologist, and she suggested I change it to plus, so I took the advice. Anyway, in summary, blood loss is bad, transfusion is worse, and there's many things you can do pre and intraoperatively to minimize blood loss. And thank you very much for having me here. Appreciate it.
Great talk. There was actually a pretty good podium, I think it was IMAST or SRS, regarding the quality of the cells in Cell Saver. Do you have any insight on that when you looked at a deeper dive? Do you think the quality of the blood in Cell Saver is good enough for transfusion, or are we potentially just doing it for our own psychology and that's not actually helping the patient?
I think there are studies that shows that using a Cell Saver causes hemolysis, and so the red blood cells are basically broken down, so they're not functioning as a red blood cell. But there may actually be just like you said, that you're just comforting yourself that you're returning the blood back to the patient. But I don't know, there's studies that shows that the transfusion provided by cell salvage, it's not effective to improve H&H. So I don't know a study about that, but I do agree with that statement, though.
I think the one important thing is that the amount of cell lysis, a lot of it has to do with the mechanics of the Cell Saver. So how much suction power is used and those sort of things. At our children's hospital, where we're always complaining about the suction power because it's so low, they routinely salvage probably 40% of the blood loss, and I don't think that's nearly the case on the adult side because we use much higher suction parameters. But
good point. Excellent.
One question. So dosing of the TXA, in your experience, what dosing kind of worked? Is there like a cutoff? Like in cardiac literature, I mean, they use much higher dose, so like 80, 100 milligrams per kilogram total. So, I think at UCSF, as you know, we have like high protocol is 30 and 3, lower ones like 10, 1 basically. Have you, from Pittsburgh and the Barrel, what do they use, and
I'm familiar.
differences?
I'm familiar only with the 10 mg per kg loading and then 1 mg per kg per hour after that, with a similar total dose that you mentioned. I don't recall a case that we reached that ceiling, that they couldn't give TXA anymore. But I think some of the variation that I mentioned is actually the stopping point. When do you stop giving TXA? Dr. Eastak was talking, I forgot where, but he basically said he keeps giving a TXA after the case is over, 5 hours after surgery in PACU. Yeah. Thank you.